Sandy Collier with this T. Leroy Jefferson Medical Society special on the opioid epidemic. I'm here in front of this cemetery, the last stop for some who may become addicted to opioids. Tonight, we begin at the end. This is the end game. No restart, no second chances, no do-overs. Life comes to an end in a box.
For closure, it makes it real. When you see a person in a casket, it reminds you that this is the end. The life is over, and the person is a memory at that point.
Jason Fuller is the funeral director for Broward Funeral Choices Funeral Homes. So, walk me through a typical day here.
So I come in every morning, get my coffee started, have a cup of coffee, try to get caught up on some paperwork, filing death certificates, creating online obituaries, meeting families, sometimes morning appointments, midday appointments, evening appointments. So we meet families, discuss their desires to have funeral services or memorial services. In between, we embalm or prepare decedents for viewing for burial.
Burying a loved one is painful. What do you hear from families?
We hear that they won't reach, or they haven't reached their full potential. Their life was cut too short, or that they can't afford services. Those are the major things.
Some of those lives cut short by opioids. There were record opioid deaths last year. How did that translate here to what you do?
Okay, so with the increase in opioid deaths, that actually, in addition to other pandemics, that actually increased business in terms of the amount of people we serve. They due to overdose or death as a result of. So it increased the numbers or the volume here.
In our last series, we talked to state attorney, we talked to police, and both say that fentanyl is the next big thing. Tell us what you're seeing in your business here.
We're seeing that fentanyl has led to an overall increase in deaths as contributing factors to overdoses, more so recently than in the past.
When a family comes through here to tell you that their loved one had an opioid problem, what is that conversation like for you?
Okay, so they explain to us the types of services. Sometimes they'll give us the background. If they give us the background, as a funeral director, you can, as a human, but specifically as a funeral director, it pricks your heart. You wonder if they were given the right resources, or if they were pointed in the right direction, or that they just didn't have the ability to overcome the issue.
You take that personally because you think that there is a lot more that needs to be done.
Correct. There's a lot more that needs to be done. Resources need to be in place, or I believe that there should be just more outreach, more preventative measures that would give them the ability to overcome the disease. Prevention as opposed to, after death. But even through death, it could be used as a resource for the attendees for the service or families to know that there are issues that need to be tackled.
How are you trying to help with that?
Okay, so we, through things like this, but specifically, we try to provide resources or point them into directions for treatment or just knowledge through resources we have, people that we know that we can refer them to, or online, a lot of online resources. But again, we want it to be a preventative thing, or it's a disease that can be overcome through treatment. I believe it can be overcome through treatment. Mm-hmm.
Because when you come here,
it's final.
Before the bodies end up in a casket, They're reviewed in an autopsy by doctors like Gordon Johnson of the T. Leroy Jefferson Medical Society. Tell me about your experience. Where were you a medical examiner?
I was a medical examiner in Missouri for 11 years. Now, mind you, I've always chaired a department of pathology someplace. So I was, in addition, a medical examiner of this county in Missouri. So I was wearing two hats, and in fact, eventually I had about 20-some counties that I was deputy coroner for. So I saw a lot of bodies.
Although you got your Florida license to practice medicine in the early 1990s, why did you not move here to practice until 2001?
Well, I started doing medical examiner work in the late 70s. And I saw some of the tolls of drug abuse, substance abuse, and I was very much aware of how it impacted different areas. And the area I was in Missouri, was nice for raising of children because there wasn't that much substance abuse. As I prepared to come to Florida and was actually building a house in Weston, I started this was in the early 90s. I saw the statistics and I knew Miami had been a portal of drugs into the country. And I just looked at how difficult it would be to raise my children in that environment or versus the one I was already in. I just decided to stay in Missouri, and I canceled out of all of my Florida contracts and later on decided to come on down.
Dr. Johnson is a pathologist and a former medical examiner. What role does the pathologist play in the fight against opioids?
Okay, I think that question's best answered by telling you exactly what a pathologist is. A pathologist is a medical doctor that studies disease. As such, we examine human body fluids and tissues. We do autopsies. We look at everything that comes out of you or off of you, surgical pathology. We look at and study the chemistry of the human body. The blood bank comes under the auspices of the pathologist, how people get blood. Microbiology, the viruses, the bacteria, the fungi, all of that is pathology. Hematology, the study of the blood cells, that's pathology. So there are two broad branches, clinical and anatomical, and my boards are in both. And what we're involved in with is looking at the drug levels, looking at the causes of death, providing instruction to the hospitals on what we're seeing so that there might be committees that adjust how opioids are used in the hospital. For instance, we just decreased the use at one hospital I'm associated with by about 90% once we saw the problems, because we're in meetings and we can talk about that. So pathologist is very, very much involved in the qualitative and quantitative analysis of the drugs, as well as the classification of causes of death and the reporting.
First of all, what is an autopsy? How is that performed on a person that died or suspected to die from an opioid overdose?
Well, the pathologist is kind of the case coordinator. So we're going to look at the scientific as well as the forensic evidence, and we're going to put it all together and provide for the judiciary, for the bar, for law enforcement, a series of circumstances surrounding the death so that we can piece it all together. We're going to collect all the evidentiary material. We're going to be the ones that do the fingernail scrapings to see if they clawed at something just before they died or someone. We're going to look for hair samples. We're going to do the fingerprinting. We're going to take various fluids for analysis for the drugs. For instance, in the deceased, we might use the vitreous humor. the fluid inside the eyeball, because it's a very good material to examine for certain drugs. We might use femoral blood, where we get blood out of the femoral artery. We might use urine. Urine's very common to particularly screen. We can do a quick analysis, screen for certain drugs, know that they're present, then we can do more detailed qualitative and quantitative analysis using sophisticated chemistries and determine exactly how much of that drug is around. So the autopsy consists of opening the human body with a Y-shaped incision here and examining all the internal organs, removing the chest plate. It also includes opening the skull and examining the brain and spinal cord. So it's an extensive examination with maybe the stomach contents are important. What was the last meal? Are there undigested pills in there? All of these things have to be looked at. And then after we put this series of circumstances surrounding death, we put this together, we have to submit it to the Bureau of Health Statistics, so that all this information goes into a database. And if drugs are involved, then the Drug Enforcement Administration has to be notified. So there's a lot of work that involves the pathologist, who is, to me, kind of the guardian of any community's health care.
How long does it take to do an autopsy?
Well, with the number of deaths from opioids that some of these medical examiner systems are experiencing, they've had to get faster. Let me put it that way. But a good autopsy, the preliminary dissection can take 2 to 4 or more hours. But what happens later is all of the tabulation of all the findings, the chemistry studies, the tissues that you have to look at under the microscope. So there are any number of things that we'll eventually put together, and so the entire autopsy might be 12 to 14 hours of time by the time you get all that information put together.
Dr. Johnson, can you define the terms manner of death and cause of death and how they relate to the opioid epidemic?
It becomes critical, the manner of death. The cause of death is, it's pretty straightforward. What killed this individual? It can be tricky sometimes, but in general, it's going to be a sudden cardiac death. In other words, a hard stop. Now, it may be a result of any number of things that the heart stopped, but in the end, that's why the person died. So a cause of death and as a result of can be a chain of events. But the manners of death, there are only really 5. So the manners become very critical when we're trying to discuss how we prevent it later on. Was this an accident? Was it homicide? Was it suicide? Was it undetermined? Or was it natural? So those are the 5 manners of death. So when you stop and think about it, if someone is laying there dead of an opioid overdose, was that accidental? Was it suicide? Or was it homicide? So the circumstances surrounding death, the amount of drug in the body, if there are new marks, and this is a new user who doesn't know, it might take very little to kill them, whereas someone that's been using it for a long time, is this something that was an accident, or did they know what they were doing? So it becomes a series of investigations, and in fact we do what's called a postmortem psychological examination, because you have to really examine that patient and think about what they were going through before they died. That helps you with the manner of death.
Explain homicide? Because a lot of people don't know what a homicide is. What is a homicide?
A homicide is when someone takes someone else's life. Now, they could very much have intended to do it, or they could be negligent and just not respecting human life like they should have. In general, when they think about it and plan it out, society as a whole is much harder on them than when it's an impulsive, crazy thing that they did.
Is it possible to perform an analysis to determine if someone has an addictive personality and therefore would be more susceptible to opioids?
Right, we're not there yet. Right now, we know that there are certain people who have substance abuse tendencies, and it does run in families. The only thing is there are no good chemical analysis for this because there are different genetic variations for different substance abuse problems. So it becomes difficult to say, oh, people that regularly will abuse drugs have this in their blood. We can't really do that.
What pathology findings are frequently associated with opioid abuse?
Well, that's the thing about opioid abuse. You look at somebody and they look perfectly normal. They look healthy. I mean, every now and then you see one of these great athletes that is all of a sudden laying there dead because they got treated for some injury, they got an opioid, next thing you know, they have a substance abuse problem, and they overdose. These kinds of things happen all the time. So it's very important that we keep an awareness of what can happen with these drugs. We stay on top of people and try to do what we can to teach them as much as we can.
What does a opioid brain look like?
You can't really tell. There's the terminally, when someone dies, they stop from these drugs, they stop breathing. Just as they depress the pain center, they depress the respiratory center. So the people just stop breathing. And when you stop breathing, you're not getting oxygen to the vital organs, they start to die. And one of the first signs of anoxia is edema, swelling. So their brains will start to kind of swell up, fluids will seep into the tissues, and the same way with the lungs. So those might be a couple of findings that you have at autopsy.
Let's talk about opioids in the Black community. What disturbs you? What have you seen?
Well, I've seen a couple of things. One, it's definitely there, and there's heroin, and there are things that cause addiction and death among the Black community. The thing that probably disturbs me more, and there are studies on this, is the stereotypical drug dealer is so often the Black guy in the hood. When actuality, if you really look at it and study the statistics, that's not who it is at all. But that's the way it's always depicted. This thing is a problem across the board, and it has it's not a Black thing like the media would tend to depict it, that it's mainly a problem of African Americans and the ghetto and the hood and so forth. There's some very great lectures by people from the American Medical Association who will tell you this among us is pretty much along percentages, and we're not highlighted at all in this epidemic.
I interviewed a person who is in active addiction right now, and that person tells me pretty much what you just said, that they want to get off of opioids, but their biggest fear is going into detox because they feel like they'll die in detox. What do you say to that person right now if they're watching?
I would say, me personally, if I'm talking to them, I would say, let me find you a program. Let me work with them. Let me talk to them about how they do it. And let me assure you, we can get you through a program safely where you're not tortured going through it. And we can get you off of this drug. There are ways. There are many, many ways, and it's very well described how to bring these people off the drug, but it's not practiced that much. You know, you saw the media, so many of the detox centers got into trouble. They were over testing and making a lot of money. It became something that was scandalous, but there are many, many opportunities to teach these people we can help them. We need to get out there and let them know. And some societies I'm working with right now are letting them know. And I think that we need to do that.
I spoke to a funeral director who was very emotional. And he said that if we don't get on top of this, we can lose a whole generation. From a medical examiner point of view, do you agree with that, and why?
Well, when you're going to the morgue as a medical examiner and bodies are just piling up, and you realize that between 18 and 45 people in that group, opioids kill more people in the United States in that group than cancer, accidents, suicide, and COVID put together. Okay? Opioids kill more people than in the 18 to 45 age group than all those major things put together. So you can see this could be alarming. You walk in and you see all these young people laying there on the slabs and they're dead, their life's over, and it was pretty much an accident. That's pretty much what it is. It was an accident. They get just to take a penny, set it down, take enough fentanyl to cover the year on that penny. If it were like, let's say, sugar, that's enough to more than kill a person. Okay? So just cover that year of the penny with that like it's sugar, and that will more than kill you. So you understand this is starting to get frightening. 100,000 people died last year in this country from opioids, well, from drug overdoses, a big part of which are opioids.
As a pathologist, you have seen autopsy thousands of bodies.
Thousands.
Tell me a story of one that stayed with you that you still think about today.
There are many, but when I see the young in their 20s and I can see those bodies laying there so cold and not breathing, and as I told you, there are deaths that are classified as undetermined, and I go in and I can't find anything because the body, as we said earlier, a person that's addicted looks like anybody else. They're normal looking people, but they have these substance abuse problems and they end up in trouble sometimes. So I got a body there. I have no cause of death until the drug studies come back. Fortunately, I had my own internal toxicology department, so I could get the results back quickly. But in some cases, it takes weeks to get all the toxicology back, and you don't have anything to tell the family. So I remember all of these young people laying there dead. I couldn't find the cause of death. I suspected it might be drugs, but until I get those qualitative and quantitative analysis back, I can't make that diagnosis. So I can see them laying there right now on the cold as can be and discolored, but there's nothing else that can be done. It's over.
What is that conversation like with the family?
It's sometimes very difficult because you've got that body there and you don't even know a cause of death yet because, and they're anxiously, I mean, here's just a young person that's been snatched from them, that stopped breathing, and frequently they don't know they were substance abuse problems. And so until that toxicology comes back, it's very rough. But then you have to tell them, and you have to outline all the different ways that this may have happened. It may have been the first time, and they just didn't know what happened. It could have been that they were a user, stopped using them, and then came back thinking they could use the dosages they had gotten up to before. That's very common. So now they go back to the dose they stopped. They've been good for a long time, and they go back to that old dose, and it just kills them immediately. So wait, they have no tolerance for that amount anymore. So it's very rough. It's very, very challenging to have to tell someone that normal-looking, great young person is dead from something that's so horribly stigmatized because they just had a little brief bout with an illness that's no different from cancer or anything else, but we treat it like it's different.
How do they move on from that?
It's tough. I mean, just imagine you have someone close to you in the prime of their life. They get this illness, and it is an illness, and it's something they can't control, and they get just a little bit to tide them over, but it's that fentanyl, which is so powerful, and it just depresses their respiration. This is something their body is asking for because of those receptors that have received it before and changed the way they're motivated. It's not in their control, but now just a little extra of this will just stop them from breathing. And if someone's not right there to reverse these tendencies of this drug, then they die.
How do we fix that?
We can fix it. It's not easy. Again, it's what, now this is where we as African Americans get another raw end of the stick. They figure we're just drug people. So the programs are not properly funded. People, there's, you're bad. You're just bad. You could not do this if you wanted to. No, this is no different from cancer. If you've got a substance abuse problem, then it's just as though you had cancer. You can't control that. When those drugs get in your system, go to that mu receptor and change it, you have no control. It changes what you want and what drives your body. So it takes you over. People that haven't been there don't understand it. And I don't understand it. But I know it exists, and I can try to understand, and I can try to educate, and I can realize that it's real. It's a real illness, and approach it like that. Not just say, those are drug abusers. So we don't really need to ease them down and detox them, because they should pay. They should suffer in the detox. And that information gets out there, and they're slow to go get treated, because it's a hard task to be treated. That's the word you get back. When we can treat those people and bring them down easier, but we're not doing everything we should be doing. So we need to get the word out there. We need to let the healthcare providers know there's a better way to do this. We can do it where we take care of these ill people who are no different than those that have cancer, and we can get this job done. We can start to see this number go down.
Can you tell us the roles of the DEA and the BNDD during the opioid epidemic?
Yes, the Bndd was the precursor to the DEA. So the Bndd was the Bureau of Narcotics and Dangerous Drugs. The Justice Department, in which the Drug Enforcement Administration works under, was over those and has always been over those agencies. The DEA gets all the information reported, and as I said, it's under the Justice Department. You also have a narcotics research branch that's directly under the president. So there are two different branches of government that deal with opioid addiction and this problem. There also is the Customs, which is under the Treasury Department. So, and Customs, of course, deals with this problem. So when you get through, you've got about 3 agencies under the Department of Justice, because they must prosecute the problems. You've got an agency of research under the president, and then you've got the Customs Department under the Treasury, all working on the same thing, and no one has a good answer. We're all scrambling to come up with some right now.
Do these agencies, do you think they help in the fight against opioids?
Yes, I think there have been some therapeutic misadventures, if you will, with regards to the way we've treated this issue by just locking people up. And if we catch them and making it a crime as opposed to an illness. It's so important for us to understand this is no different from cancer or any other illness. The people can't control it. So these agencies have enforced and been punitive when in fact we need to do what we can to take care of people and treat them as though they have a disease, just like cancer.
Dr. Johnson, we have a lot of doctors listening. What advice would you have for your colleagues here?
I want them to understand that this isn't something we say happens to bad people because they chose this. I want them to understand you give them those drugs, and a certain percent of them are now diseased, and it's out of their hands. You gave them that drug. And so colleagues, be very, very careful with the use of this drug and screen for tendencies for abuse. Be very, very careful with it. And then when someone gets it, treat them just like you would someone with cancer or some other disease. Don't act like, oh, you're bad because you could control this. No, they can't. So my advice to my colleagues is don't give it unless you absolutely have to. School the people and educate them on how they handle it and use it. And then if they do have a problem, treat them like they should be treated, like someone with any other disease. This isn't something that you be punitive about.
So until we treat opioids like a disease, we're still going to be fighting this battle for years and years to come.
Until we treat it like a disease, just like we respect other diseases and not act like, oh, that's your problem because you did this. And we understand, no, it's not. It's no different from any other illness that just falls upon you.
Our funeral director agrees. As a funeral director, you want business, but you don't want this kind of business.
Correct. We prefer families to come in that have not been affected by an opioid death. But it can be prevented through education and resources, treatment. It is a disease that is a psychological issue or a psychological component, has a psychological component to it that can be treated. And we would hope that people would reach out and look for resources that can help treat this disease. But I can say that a lot of families are not aware or they're not aware as to how serious the use was or the addiction was. Some of them may not even know there was an addiction, because people hide their addiction. So some families are not aware. Some families are not aware of the seriousness or how bad it is until until the person is found or they've overdosed. Because that's the reality. I get a lot of families, they don't know. They just don't know. And it's like, not my child, or some are in denial, but I don't think some are in denial. I think some just don't know. They don't know how bad it is or that they were using, because drugs are something that you can hide. It's only when sometimes if you need the resources or things start, going missing that they may say, oh, I had money here. But if that person does not steal or does not take, how would someone know that they're using? They can hide it from their families. And in a lot of cases, that's what happens. But, treatment, I think, could help that, or available resources. What's the word? In the, not detox, but the facilities, like residential, I think that's how they're going to be able to overcome that disease. Yeah, because it's a disease. And it can be overcome. Tons of people in recovery for 20, 30 years. So it can be beaten if they have the access to the proper resources.
So it's an ongoing.
It is an ongoing. You think about it, someone that has 30 years in recovery, they faced this disease 30 years ago. It may be opioid or it may be fentanyl now, but it may have been another substance 30 years ago. So it is an ongoing thing, and we can't sweep it under the rug. We have to deal with it because it's affecting other communities now. But you can no longer sweep it under the rug or act like it's not there. It's here, it's here. And then with the pandemic, I think that exacerbated, the use being in confined spaces or not being able to go to community meetings or not being able to find treatment. I believe that just made the problem worse.
And we all need to work on this problem.
We all need to work, yeah. Yeah, because whether we know it or not, it affects everybody's family. It's not just my family. It's people I grew up with, people I know. Whether I serve them or not, it's people that we all know. Everyone, I believe, in this United States, everyone in the world is touched in some way, shape, or form with the opioid crisis, whether we know it now or we'll find out in the future. And for some, it'll be the near future.
You're emotional about this.
Yeah, because it affects everybody's family. Mine, everybody's. Yeah, it affects everybody's family. We just need to make sure that there are resources in place and that we can point them in the right direction. And when they're in treatment, don't look down on them because they are seeking treatment. It's a stigma that, people in treatment are those people. Well, it could be us. For some of us, it is us. It could be us. But, people look down on others that are in treatment, and that shouldn't happen.
We have actually, it is a huge contributing factor to, I think, why people of color are less likely to go into a treatment facility.
Yeah, because we don't want anyone to know that we're in rehab. Yeah, I agree.
And our families don't want to talk about it. They want to pray it away.
And prayer works. Faith without works is dead. So you have the Christian aspect, which is the basis of a lot of treatment facilities, the Christian or God or the Christian aspect. But that's the basis. So you need to put the work in as well. And we talked about self-accountability. Self-accountability. That's where the self-accountability comes in. So we have the faith aspect, but we need to work, and as a community, we need to work and make sure there is no stigma in someone seeking help. I mean, if someone goes in for mental health, they're seen as crazy, or if they go into rehab, they're seen as like a crackhead. I mean, they need the help. That's why they go into the programs. And why should it be a stigma against, or why should people look down where these people are trying? Because it could be us. It could start, with an accident, that you started taking pills and now you're addicted before you know it. you're addicted to pills. And it seems like it's not possible, but I know people that it's happened to. It starts out with something as simple as a knee injury or an accident, and they abuse pills. So it could be any of us.
And in our black race, we're seeing a lot of that.
Absolutely, absolutely. I don't know if it's because we just know. I just know more people in my race, but it is an issue that is starting to come to light a little bit more in our community. Yeah.
Young black male that's listening to you right now, that's sitting there and struggling. I need help. I don't. Nothing's wrong with me. Something's wrong with me. People are going to look bad at me. What do you say to them right now?
I would say seek treatment and forget what everyone else says. You want to live, or you have family to live for. A lot of our black males have children. You have children to live for. Seek the help. It's there. It may not be readily available, but it's there. Seek the resources to get the help you need. Attend the meetings. If you're in recovery or 1 foot in, 1 foot out, seek the treatment. Stay in treatment until you are able to overcome the disease. We can lose a whole generation, or have lost a whole generation. Yeah. Yeah, you think about the ages that it affects the most, sometimes at 20 to 25 or 28. So you figure that's an entire, that's about an 8 to 10 year segment that we're seeing it in. So we're just seeing the ones that pass away from it. So if you take that, that's an entire generation that's affected. Yeah. I just wish that we could help more. Not everyone that suffers from this disease can get out of it, but they can seek treatment I shouldn't say that. We can't help everyone, but there's someone that we can help. It may be, you may be this video may help someone that hears me. A friend of mine said to a gentleman once, they were in a meeting and he spoke, and she heard him. He was talking to her, and that helped her out of her situation. So maybe this would help someone in that light. More needs to be done, because when they come here, it's the end, it's final. Death is the end. At that point, we cannot help the person that passed away. We can provide resources or methods for the living, but for that person, it is final.
What a wonderful first section. Thank you guys, everyone, for being here. Thank you tonight on our first session. And we've got question and answer period. We've got about 10 minutes so we can take some questions from anybody out there. And we're gonna go right ahead and start with Jason Fuller. Jason, I got a question here for you. How can we as a community on the whole connect opioid users to treatment? And you started talking a little bit about that in the interview. Can you expand on that a little more?
I believe getting them the proper resources, having an idea of treatment facilities, or people that can, counselors that can direct them, or community resource programs that we just know and have readily available, a little list that we can recommend to those that need the help.
And Jason, I got another question here for you. Someone
Sure.
is very interested in, why did you want to become a funeral home director?
I wanted to become a funeral director to make money, but that didn't happen. But I also wanted to help the community. That's really why. But I thought it would be a great way to interact the religious aspect, of course, along with being able to serve families, a servant at heart. Mm-hmm.
Dr. Johnson, thank you so much for being here this evening. I had a wonderful conversation with you, and we've got quite a few questions for you as well. The first one is, how often do you communicate with law enforcement when doing an autopsy for a patient?
Back when I did it, I'm retired now, but back when I did it regularly, or the typical forensic pathologist or anyone involved in autopsies on a regular basis, it would be almost daily. So you were constantly involved with law enforcement. Again, you needed to comment, be the case coordinator, and comment on the circumstances surrounding death. So you had to put together a puzzle. I used to go to a scene of death and autopsy everybody immediately after I left the scene. Very unusual, but I got fresh information, and all of law enforcement would come to my autopsies. So they all showed up at the autopsies immediately for any cases I was involved in when I was a medical examiner.
Is it difficult to determine the manner of death of an opioid user by yourself, or do you need, and you just started to say this, you need some additional information from the community to make that decision?
Yeah, yes, you need, as I said before, and talked about the postmortem psychological exam. You need to know about that person, about their usage. Were they known to use it? Would this be something novel to them that they never used this, but now they tried it and boom, they're gone? Or they were, but they've been clean for a long time and now they've gone back to the old dose and it's just too much. They didn't build up the tolerance to it. So there are all kinds of things that you have to put together to really know and provide for that, those circumstances surrounding the death.
I have another question here for you, Dr. Johnson. How do you think doctors look at the hospice patient? I have one of the questions here says that they've had a problem with when production of opioids were reduced without considering the hospice patient. So how do you balance that?
That is a very interesting, and I just saw one of my good friends on asking questions, who is very involved with hospice patients. Under those circumstances, our main job is to keep people from pain and suffering. That's what we do. So it's very important that we have these medications. There are terminal people. That's a whole different approach to how we do it. But what we have to understand and know all that it takes to keep those people out of pain and do what we can in those situations, we should do it. Beat that mu receptor in the brain down. They should not be in pain. But the people that are going to have a tooth pulled or some other minor thing where they used to give you 20 or 30 of the semi-synthetic opioids just to take at your whim, that is very dangerous. We need to stop that. And for the most part, among the educated, it's been stopped. But for my good friends in the hospice business, it's full throttle what they need to do what they need to do. That's a different thing.
Jason, I have a question here for you. Do you believe that over the next 5 years, you will see less opioid deaths in your funeral home than you currently do? And what are the steps that we would need to take in order to reduce these numbers?
I don't believe we'll see less deaths. I think we'll see more, and maybe an exponential level. And to reduce the deaths, I believe treatment or knowledge of programs that would help. I had a family come in today that I served today. A similar situation or same situation, and it is a repeat offense, and it started on something like an accident, and the medical prescriber was not aware that the gentleman had an issue. So he kept upping the dose until it was out of his control. Thankfully, he's still in treatment now or in recovery now, but another member of the family did pass away. So it is not getting better right now. It is getting worse. But I hope that with treatment and programs, then things would get better.
Dr. Johnson, if a toxicology report for a deceased person takes weeks to come back, does it adversely impact your ability to determine the cause of death? Does the body decompose tremendously over that time?
Okay, now you said if a toxicology report comes back,
takes weeks to come back. Does it adversely impact your ability to determine the cause of death?
Yes, it does. Now, you then went on to say, does it decompose or something? That no, most drugs can be found at the levels at which they produce death in the undecomposed body. Now, if there starts to be some decomposition, not only the body, for instance, can manufacture alcohol in the decomposing body, so you can come up with abnormal levels. So decomposition can throw off levels in certain things. It can in drugs as well, but usually not too much in the drugs. And most of the bodies are found and the drug analyses are started immediately. It just takes a while to get them back. At least that seems to be a common situation. And you can't really determine the cause of death until those levels are back. You can't.
What are some other additional measures, Dr. Johnson, that you think can be taken to help combat opioid addiction?
We need to go to the right places to talk about it. And really a lot more media needs to be done. What I see over and over, I think all these things are handled appropriately and that the government does a good job but I find out that there need to be more common sense people available for some of these positions. I can't believe, for instance, from a pathologist standpoint, I know people that made millions of dollars off the drug analyses of people in treatment centers. It was a huge waste of tons of government money. It was fraud-like, and they were driving around in Ferraris and just thinking, how stupid can the government be? Can someone speak out and stop that and put that money in the right direction? I think they're frustrated, so they start throwing money at things, and it's ill-directed.
To the person that is struggling with substance use disorder right now, Dr. Johnson, and they're listening, what would you say to them right now that we talked a little bit about this in our interview that, some people are very leery about going to treatment. What would you say to them to help them to get to that next level?
I haven't been on that end of it, and I'm starting to think about that. But what do you tell these people? They need to go and find a treatment center. They need to find a treatment center. They need to interview the treatment center. So what I can say to them is become educated. You have something you can't control. We need to let people know that. You have an illness just like, and I always say this, cancer. You can't control it. There are ways for you to get help. You need to go and you need to interview places that are supposed to take care of you and get you out of this. And you need to ask these questions. And we need to get that information out there to the people that are addicted. Go to these centers, ask these questions, and let's find some good ones for you.
Jason, what do you say to, you can't help a person that's already gone, but what do you say to their family members if they have other members of the family struggling with an addiction?
To help destigmatize, let them know it's okay to seek treatment, and also the most users know other users, so they can be that light. They can bring others into recovery because they know other users. They use with other people. So we encourage them to seek treatment, get the help that they need, as well as bring others to get the help as well.
I'm going to say thank you to both of you. This was a wonderful, wonderful session. Dr. Johnson, thank you so much. Jason, thank you so much. And to all of you who are joining us, thank you guys very much. I'm Sandy Collier, I'm your host. There will be a QR code to scan for you in the end for your free CME/CE credit. Don't forget to join us on our next episode of the opioid epidemic, and that's going to be on April 21st at 6 p.m. So we're hoping that everybody would join us. If you know anybody that is struggling with opioid addiction, or anybody that just wants to learn more, medical students, anyone, just invite them to join us, because we have a lot more coming up in the next few months. Thank you guys so much again. I'm next time.
Thank you.
On behalf of our organization, we would like to thank you for electing to take this opportunity to learn. We also would like to thank our team and panelists for helping us make this project possible. If you would like more information on T.D. Lloyd Jefferson Medical Society, please visit our website at tljmedicalsociety.org.